But before we go on, I know that we are conducting this not only on this platform, but also on OrthoTV. And the attendees moderator for this evening and large parts of Asia. So I will take this opportunity to wish all of you a very happy moderator. And with that being said, I will pass this on to Jay.
Good evening. Welcome to tonight's AO Trauma Hand Masterclass Series, Assessment and Management of the Unstable DRUJ. Our master surgeon tonight is Dr. Thomas Fischer from the Indiana Hand to Shoulder Center, and we're really excited to have him tonight.
97 of bio.
I'm Jay Bridgeman. I'll be the moderator tonight. I'm from the University of Missouri, and I'm pleased to have Peter Rhee with me from the Mayo Clinic, who'll be handling our question and answer session. And then we're excited tonight to have, from a therapy perspective, Jessica Fischer from the Indiana Hand to Shoulder Center, who will also be giving us some perspective from the therapy side. Just to go over some housekeeping things, these are our disclosures for our faculty tonight that we want to make you aware of. This is our agenda to tonight. We're going to try to wrap up at about 10 after the hour. We've given a majority of the time for Dr. Fischer's presentation, but as well as going over some of the rehab principles with Jessica. And I've got some cases that we could go over if we have time, as well as going through the audience question and answers with Dr. Rhee. We want to remind you that you can receive CME credit. A link will be sent to you 24 hours after the conclusion of the series for an evaluation questionnaire. When you complete that, a link will be provided, and that's how you can claim credit and get your CME. We want you to be aware of that. This is a content validation statement. We'd like you to know more about AO North America, a little bit about what we do as an organization. And then for Zoom etiquette, all of your microphones have been muted and your videos have been turned off, but we'd really like you to participate through the question and answer section on the Zoom platform. The chat function has been disabled except for faculty, so please use the question and answer so that we can get some audience participation going. And then finally, just a summary of our learner objectives. I won't go through these in detail, but these range from identifying radiographic indications for the surgical procedure to defining appropriate surgical anatomy, recognizing pitfalls and how to strategies to avoid them, and reviewing pertinent literature for our topic tonight. And with that, I'd like to pass the baton to Dr. Fischer. So thank you, Dr. Fischer, for being with us tonight. I'm going to stop sharing.
Thanks, Jay. Let me get the proper screen shared here. I take it you can see my presentation now?
Yep, here we go.
Okay. My name is Tom Fischer, and thanks to the introduction, Jay and Chai. The North American Hand Education Committee is less than 10 years old, but has brought some incredible content during this time of the great pandemic. And I've been happy to participate in this ongoing education program. I'm really happy to be here tonight. And I'm just trying to find my correct presenter mode here. There we go. I take it you can still see my slides just fine. My conflicts have been adjudicated. I do take some money from Cynthia's time to time for technical writing, but that's about it. I'd like to thank my partner, Bill Kleinman. I take it my slides aren't going here. Sorry.
Oh, they're not advancing. You want to take it down and try to share again?
Yeah. Can you see it now?
Nope. Oh, it's coming up. There we go.
Yeah, there we go. I get my taskbar off here so I can see my slide advance. Here we go. Are my slides going forward?
No.
For whatever reason, I'm not able to.
You've tried enter, space bar.
There we go. How's that? There we go. It's just my my taskbar was overshadowing it. So I'd like to thank Bill Kleiman, who has kind of focused me on my one postage stamp size area of the anatomy for the last 33 years, and has really helped me understand this concept of this tiny little piece of real estate. But I'd also like to thank Andy Palmer, and everyone who listens to this talk tonight should go back and review Andy Palmer's initial work in 1993 and subsequent years, his work, who really brought pathology of this little area to light. And, we used to call it an ulnar-sided wrist sprain before 1984, when we first started realizing that there was pathology over here when we started sticking arthroscopes into the wrist. And I'd like to thank Gary Paling, Terry Whipple, and Champ Baker, who were the guys that got me started on wrist arthroscopy and gave me a great understanding. I'd also like to thank Jeff Greenberg, my partner, who gave me a couple slides and a couple cases for this talk. We'd like to go through indications, techniques, pearls, pitfalls, complications, and outcomes. Probably won't get much to outcomes, but we'll try. Remember, this is a unifying concept, the forearm axis, and the TFCC is just one little component of it, but it makes up a forearm joint, and we're going to talk just about the distal end of that joint, the distal radial joint, and how it affects wrist pathology and forearm pathology. And like I said, it's a postage stamp size piece of real estate that has a lot of small details to it. But in the blue are the important deep ligaments. And I call these the foveal ligaments or the deep ligaments. They're called the ligamentum subcruatum by some, and others just to say that's just a vascular anomaly or a vascular vestige. It's really not what was described as the ligamentum subcruatum, but nonetheless, the deep fibers or the foveal fibers are the important guys. The green fibers are the superficial ones that attach to the styloid, who are always indicated by styloid fractures as their avulsion. But this, in combination with the bony constraints of the curvature of the sigmoid notch, this is like the glenohumeral joint. Think of the distal radial joint like the glenohumeral joint, with a shallow glenoid and a more rounded humeral head. And it does rotate and translate. It's a slide and glide joint, so it's inherently unstable. And we need to add some stability to it. And so extrinsic stability, in addition to the TFCC and its ligamentous stability, it's the ECU sheath, the pronator quadratus, the interosseous ligament or the distal oblique ligament, and the distal interosseous membrane at the inferior part of the DRUJ. We'll talk about that a little bit more later. It's a dual action joint. It has both a ulnocarpal component to it as well as a radiocarpal component to it. And that piece of that radiocarpal is part of that forearm joint. Remember, our wrist loading is about 80% of on the radius and about 16% on the ulna. As you load the wrist, it shifts over towards the ulna just a little bit. But remember, this lunate fossa here and the proximal or the distal radial ulnar joint, the so-called sigmoid notch, they are integrated to each other. So injuries of the scaphoid or lunate fossa and the distal radial ulnar joint are inextricably linked together. And then you surround it with all these ligaments down here and you get some form of stability. The best thing I can say tonight is I fixed the TFCC when the hinge is broken. And when the hinge is broken, that means that it's either got a minor instability or a major instability. And I think some of the minor instabilities are about like tennis elbow. They hurt, but they don't really cause gross instability. And we'll go through some of those. We're not going to talk about central flap tears tonight. These are not really a source of instability. I guess you could call them a source of instability in linear loading, in the fact that the disc moves around in an abnormal fashion. But the 1A palmar central tear is pretty easily treated with a scope and debridement, and is one of those home run operations. Instability, let's define that a little bit. The loss of the capture of the sigmoid notch. And it can come from radial malunion, or it can come in from alteration in the ligament tension, from malunions, or from displacement of fragments that the ligaments attach to on the radius. But it's a loss of ligamentous support that can be purely soft tissue, and also can be associated with the deep styloid fracture. And really the base of the styloid isn't the fovea. The base of the styloid has still got those superficial ligaments on it. The fovea is just a little bit displaced, a little further inroad. And the displacement, though, of these styloid fractures can suggest foveal avulsion. And so stability is really given to us by the bony contours, the gravity of the compression load, muscle tension, the ECU, the pronator quadratus, and others, the IOM, especially the distal components of the IOM, and the TFC itself. For me, there's two kinds of instability. One is a minor instability that's it hurts, but it really doesn't clunk out of place. And those include dorsal marginal tears of the TFCC, the so-called 1Bs, the subsheath tears, the ECU, where we detach the TFCC from the stabilizing influence of the ECU tendon and the 5th and 6th dorsal compartments. You really detach the tendon and its vertical structure off the rim of the TFCC. And then there's partial foveal tears, where the deep ligaments are just partly injured. They're unstable enough to be painful all the time, but not unstable enough to allow the joint to clunk out of place with its natural slide and glide instability. The major instabilities are really the complete tear of the fovea, where the distal ulna subluxates off of the distal radius. In actuality, it's the distal radius subluxating off the distal ulna, because remember, the ulna is the stable member of the forearm. And then there's gross instability of the ECU with subluxation and translocation, and it can become completely detached from the TFCC and its 6th dorsal compartment. Symptoms include ulnar-sided wrist pain, which I think at last count I had about 24 conditions that have been described that create ulnar-sided wrist pain. It's worse with rotation and grip, especially ulnar deviation, rotation and grip, and pronation. And there's mechanical complaints like clicking, catching, locking, and you really got to correlate the findings you have with the physical exam with the history. And you can talk to them about gripping and twisting, hammers, wrenches, screwdrivers, and those kinds of things. The physical exam is pretty straightforward. You can use an eraser tip and push gently on the fovea, or so-called Berger's point, after Dick Berger described Berger's point, also known as the foveal sign. And then there's instability, where you can shuck the distal radial ulnar joint just out of its realm on the radius. I don't use a lot of advanced imaging, but I do when I need to prove a point or to exclude other problems, such as especially Kienbach's disease. And then arthroscopic evaluation for me is helpful, but you really can't get to the fovea very well arthroscopically. You can see it indirectly, feel it indirectly, but you really can't visualize it directly very well at the arthroscope unless it's just grossly unstable. Then you don't need a scope to make the diagnosis. For me, the Berger's point, it's just south of the ulnar styloid. It's a place where between you and your examining finger and the TFCC, there's no other contravening structures like the ECU or the 5th dorsal compartment or the ulnar artery or ulnar nerve. And so that's also known as a foveal sign. It's a very specific exam. It's got very specific tenderness. It's not the tip of the styloid tenderness. It's really volar to that. You can do stress loading, and then you can do shucking and mechanical signs of instability, but always compare it to the other side. just get the other elbow up there in the table and give two comparisons. Even your thumbs are pretty heavy sometimes, so press them with both thumbs at the same time on the fovea on Berger's point really can help you if the patient's a little jumpy and every time you press on them, they react. For me, this is my favorite. This is taught to me by Bill Kleiman. This is one of our fellows. Mary, she's examining this wrist, and you put the wrist in supination, elbow stable on the table, and you translate the ulna towards the patient with the palm facing towards the patient. And so when you displace that ulna palmarly on the radius, you're displacing the radius dorsally on the ulna, but palmarly on the radius, you're really testing the dorsal deep ligament, the opposite ligament from the direction you're pushing. And then in pronation, with the hand pointed towards you, and you translate the ulna dorsally, you're really testing the volar deep ligament. And we'll go over that in a few minutes in the anatomy piece of this. But these two tests, where it can recreate, and many times they'll recreate in supination, but they won't recreate pain in pronation. And then you can kind of tell which side is a little more affected. But this is my favorite stress test for the distal radial ulnar joint, besides ulnar grind, which really tests the axial portion of the TFCC. Advanced imaging, MR and MR arthrogram, our local radiographers, our musculoskeletal radiographers are starting to go away from MR arthrogram, and they'd much prefer just having the joint fluid in there and to give them the contrast they need with the 3 Tesla magnets. So the CT scan, I rarely get CTs unless I want to have it with comparisons. Without comparison, I don't think CT helps me with axial alignment of the ulna and its relationship to the radius. But you really have to evaluate it in neutral, pronation, and in supination, and compare both sides and make sure both wrists are locked in the gantry correctly. And that's a lot of control you have to get good CT comparison to the other side and to make a decision based on that type of displacement for me. The one thing that MR helps me with is ulnocarpal impaction and Kienbach's disease, the bright white signal you see in the very ulnar corner of the lunate and in the triquetrum also, and sometimes the TFCC defect. So MR is really helpful for me to exclude that and also to exclude Kienbach's lunatomalacia. In addition for me, this sign right here, and this is Jeff Greenberg's case he gave me because it's the best illustration I know, where you see the let me get over here to my screen. You see the fluid go all the way to the styloid. There's nothing stopping it in the fovea. It goes all the way to the styloid. For me, that's a complete foveal avulsion. And here's the intraoperative picture that shows just a bare end of the ulna. He didn't have to do any real dissection. And this young lady had seen 7 different docs, only one other hand surgeon, and she referred this patient on. She's a college volleyball player, got seen by 3 or 4 sports medicine primary care docs, and finally got to somebody who could do the exam. And sure enough, she had gross instability and the foveal avulsed, and she got back to playing after foveal repair. And so Dick Berger first described the displacement of the ulna on the radius to diagnose foveal detachment. And it's a subtle change between the two. It's a difference between 16% displacement versus 5% displacement. And it depends on where you draw your lines. So a little bit of this is measuring it with a micrometer, marking it with a piece of chalk, and cutting it with an axe is my favorite orthopedic axiom. We get down to these tiny little measurements, and you really don't, it doesn't benefit me as much. I look upon the fovea as a spot weld, and here's an illustration of a classic spot weld, and it's got engineering criteria that go with it, but in the center, it's really strong. It's very small, but it's very strong.
And that's really what the fovea is, and it's interior to the base of the styloid. And here's a good illustration by Gary Schnitz and Bill Kleiman that shows the deep ligament or the foveal ligaments as opposed to the superficial, more capsular ligaments on the radial or the ulnar styloid. So here it is from above again, and you can always tell where when you're looking at an axial view, we'll always look for Lister's tubercle, always look for the big teardrop over here, and always look for the notch on the end of the ulna where the ECU is. And so you'll be able to orient yourself quickly if you see that Lister's tubercle, the big tongue of the lip of the foot, or the teardrop of the lunate fossa, which is very elongated and gives you that great buttress on the palmar side, is why many times these are quite stable in supination, because you've got that good bony buttress down there. And so here's that illustration where you look at the slide and glide characteristics. So in extreme pronation, you only have about 10% surface area in contact, and it's in contact with that more shallow dorsal rim. In supination, in the extremes of supination, you've got that great bony block of the teardrop of the lunate fossa. And in neutral, you're really stacked. The radius is stacked on top of the ulna, and that's the greatest bony constraint. So when your forearm's in neutral and you're lifting like a hammer curl, you're really stacking one bone on top of each other. And remember, the ulna lifts the radius, and the ulna is the primary lifter of the forearm. The radius just floats around like a bucket handle around that distal end of the ulna. So when you're in pronation, supination, you're relying on the ligaments to do your stability for you in lifting. But when you're in neutral, your ulna lifts your radius quite well with good bony contact. And so here's that deep ligaments, the deep fibers. You see the cartilage, you see the more superficial fibers there, the TFCC on top, and the distal radial ulnar joint and the seat of the ulna on the radius. And so with that in mind, remember, here's pronation because the Lister's tubercle's on top, and your ECU notch is on the dorsal side over there. And you remember that when you're in pronation, palm down, it's really your palmar fibers that are keeping that ulna from translating any more dorsal. The dorsal superficial capsule is taut, and the deep ventral fibers are taut also. The deep fibers are lax on the dorsal side, and the superficial fibers are lax on the palmar side. It's just the opposite in supination. Here's supination with the Lister's tubercle pointing down. The ulna is up against the teardrop of the lunate fossa, and you see the deep portion of the foveal ligaments is taut on the side opposite where the head of the ulna is headed. So remember, the deep fibers are opposite the direction you're going. So here we are at the scene of the crime. Here's a complete ECU dissociation. So this is one of the extrinsic stabilizers of the TFCC. Besides the intrinsic stabilizers, which we just looked at, here's the start of the extrinsic stabilizers of the TFCC and the ECU and its stability. The other piece of that stability is the joint reactive force that occurs here when the ulna lifts the radius. And here's the entire forearm with the brachialis lifting the ulna and the ulna lifting the radius, and the IOL keeping the radius from translating more proximally. So distally, you really have the TFCC that keeps that joint from sliding in and out. And then longitudinally, you got the IOL to keep it from shortening too much. So the load carried by the hand is directed through the wrist onto the radius, then onto the ulna via the sigmoid notch in the radius. And here's our force diagram with a very small lever arm distally, very long lever arm in the radius in the forearm, and very small amount of force on the proximal radial ulnar joint when you're lifting. So the greatest joint reactive forces there at the distal radial ulnar joint. And these intrinsic and extrinsic ligaments keep that ulna from sliding out, and that's when you get the clunk. So the palmar soft tissue has been known for a long time. So here's the superficial stuff, which is pronator quadratus, and its components of helping try to stabilize the distal radial ulnar joint. And Bob Hotchkiss has been a long-term friend, and he was my teacher when it came to that IOL and how its anatomy is fairly variable and also fairly complex. And the distal fourth has really been well defined by the Japanese. Moritomo from Japan has done a number of dissections, and he's really shown that the three distal ones, the distal oblique ligament and the central band and the accessory band, are really the three isometric components of your forearm interosseous ligament, and in combination give you stability in both pronation and supination. And then the dorsal oblique accessory cord, the proximal two, are somewhat off axis and really not isometric, but do give you linear support. So the radius transmits the load of the ulna through the IOL, and the distal oblique ligament also helps to stabilize the distal radial ulnar joint. I just don't know how much that DOB plays into minor and major stabilities because it is so variable in the human population. I have to give a shout out to Andy Palmer with this slide, as he gave us these four basic lesions of the TFCC. I don't really use them much. I'm sorry, Andy, but I go for a foveal tear, a marginal tear, or a central tear. And those are my kind of three things. I'm an orthopedic surgeon. I don't go for four things at a time. I go for three things at a time. So here's our techniques. And my four repairs for the TFCC, one of them is the debridement we decide we aren't going to talk about, but ulnofoveal tears, partial and complete. And those, I think, require a drill hole in the end of the ulna to get them to work well. Dorsal marginal tears, aka the ECU subsheath tears, retinacular tears, or red zone tears, the red zone being the vascularized zone on the dorsal or palmar side. And then there's the palmar ulnocarpal ligament tears, those that can turn into VC. And there's all these longitudinal split tears, which Lee Osterman has been a champion of describing. For me, they're infrequent and stable, but a source of pain. But the palmar ligament tears can be catastrophic at times and need attention. We're not going to talk about them a lot. And then there's combinations of all three. But for me, the foveal tears and the dorsal marginal tears are the two biggies, and we'll talk about those the most. So for me, any open repair for me is any foveal repair is really an open repair. There's plenty of great arthroscopists out there that can get the hole in the right spot and can get things anchored in the right place. But for me, I like to drill a hole in the end of the ulna, put an anchor in, and sew things down one piece at a time. And whenever I drill the hole in the distal ulna, I chant, release the stem cells, because a hole in the distal ulna gives you every component you need for healing. It gives you vascularity, it gives you stem cells, it gives you a healing response, it gives you all the PRP you want. And I think it's just the best way to stimulate healing in a somewhat minimally vascular environment. And so for me, the instabilities are a foveal repair. MRI helps me with signal change at the fovea of the central fovea of the ulna. Radiographic subluxation criteria help me, but arthroscopy with putting a probe on it and pulling on it is one of my gold standards for whether or not the fovea is partially or completely torn. And for me, the only time I use graft material is when I've had some other operation in the area, an open injury, such as a machinery injury that has removed soft tissue. But for the most part, I think for sport-related and low velocity-related injuries that haven't been operated on in the past, you got plenty of tissue to make that spot weld happen again. And I only use grafts in pretty much secondary surgery or when there's been loss of substance. For me, the pre-styloid recess, anything palmar to that or central to it is more of a foveal injury, and anything peripheral to it, i.e. underneath the ECU subsheath, is really a dorsal marginal tear for me. And that's the so-called 1B tears. And so the foveal tears are more instability, and the dorsal marginal tears are more of a pain and not so much instability. For me, foveal repairs, you really have to get rid of all the granulation tissue that's there. There's usually quite a bit. To breed that, I use a palmar approach and go right through Berger's point. I leave the ECU tendon on the dorsal side. I know my partners, they'll go from the dorsal side, and that's a perfectly good approach too, but I just feel more comfortable going in from the palmar side. I use a large drill to put a hole in a bone anchor. You can use whatever bone anchor you want, but I usually have 3 separate sutures, and I use a MyTech anchor just because you can thread extra sutures on it that are different sutures. And I use a absorbable suture for the central portion of the TFCC, and then I use non-absorbable sutures for the dorsal limb and the palmar limb, and tie those all 3 to the same anchor. And so here's the anchor going in. Here's the fovea. On the left, you see the erosion at the fovea. You see a small avulsion fracture that ended up being a little bit bigger piece than we thought. And so ends up with a little tension band and a pin to hold that dorsal capsule or that superficial capsule down. And then the second anchor and the small anchor's got the tension band on it. And then the big anchor's got the 3 sutures on it. And you can, the nice thing about these MyTech anchors is you can throw a couple extra sutures on for insurance purposes. But for me, I like to use absorbable sutures in the TFCC and the intra-articular stuff. I don't like fiber wire in the joint. So the anchor characteristics is it doesn't have to be absorbable, but it should be static. It should have some freedom to add some extra sutures to it. I like suture anchors that let you run the sutures through the eyelet and pull tension on one side by pulling on the other. And I usually do the subsheath tear associated with the foveal tear with one of those sutures on the anchor. And you can do combination injuries with these 3 sutures. You can get the dorsal side, the palmar side, and the central TFCC. I don't pin these very often. They have to have gross instability. And if I'm going to feel like I need to pin them, I actually put a box frame on the forearm with an external fixer with 2 pins in the radius, 2 pins in the ulna. And that way I can adjust my relationship between my radius and ulna very accurately. Dorsal marginal repairs are fun to do. They're like lateral meniscus repairs in the knee. You can use a lot of different soft tissue techniques, a lot of different arthroscopic techniques, but everything basically comes down to the basic same thing. You got to avoid the dorsal sensory branch, especially the aberrant or the variation of anatomy, the transverse branch. You don't want to include the ECU tendon in your repair. If you catch it or snag it, you will have a chronic ECU tendonitis. And your knots, if they're tied inside the ECU tendon sheath, can cause chronic tendonitis, especially if you're using a PDS suture that's long-term absorbable or a permanent suture. You got to let the ECU go. You got to let it glide, and you can't be scooping it up with your repair. And almost all these repairs really reintegrate the vertical septum between the 5th and 6th dorsal compartment to the TFCC, the so-called subsheath. And so you see here the vertical arrow is on the ECU. You see that big, robust sheath underneath it. You're looking at the inside of the joint here. And right where that black probe is kind of the vertical septum between 5 and 6. But you're really trying to tie that back down to the dorsal rim of the TFCC. Think of the TFCC as the floor, the disc is your floor, and that ECU tendon is a vertical column like you'd have in a building where you got to tie the floor to the vertical column to make it stable. And so there's a variety of ways you can tie that ECU subsheath, fifth and sixth dorsal compartment, back down to the rim or the green zone there, also the red zone because it's vascularized. But somehow you got to get that ECU back down to regulate the tension on the TFCC. And so you really want to reintegrate the ECU with the TFCC, just distal to the tip of the ulna. And so 2 sutures, you can put one on the ulnar side, one on the radial side. A lot of times I'll just put 2 sutures on the radial side, depending on the configuration of the tear. But you really want to get that capsule back to the floor of the ECU. You can do it arthroscopically. It's fairly straightforward to do. And you go between the 5th and 6th compartment. You use these instrument maker needles or TUI needles or any type of suture in and out passing needles. There's so many good techniques for passing it arthroscopically. But basically, you seal that edge back to the rim of the TFCC. You exclude the joint fluid that's bathing that area, and you tie it back down, and then you immobilize the patient. And I think Jessica, one of our hand therapists, is going to talk about that just after I shut up and quit talking here. But for me, vertical problems, namely ulnocarpal impaction problems, is you really need a different kind of exam, and you really need zero views and grip views, and then advanced imaging to look at the lunate. And that's a whole different talk, I think, is ulnar shortening osteotomy, which is another one of my favorite operations of all times. But arthroscopy for me is a gold standard for the subsheath tears. It's both diagnostic and therapeutic. It is technically demanding. There's a lot of great techniques out there, and it has a learning curve. I thank Terry Whipple and Champ Baker for introducing me to the arthroscope in 1984. And I really think since that time, we got better equipment. We got smaller equipment. We got HD cameras. We got great jet pumps now that really regulate the flow. And you can do dry scoping because we have such good HD cameras now. And intra-articular manipulation and intra-articular repair are a commonplace now, or they were difficult at best in the early days. Yeah, I think you can do an exam under anesthesia with the scope in, and it can kind of help you decide how stable that TFCC is. There's a thing called the trampoline effect, where you just lose all the tension of the TFCC. The hook test, where you stick a hook in and pull on it, see if you can displace it away from the fovea. And then you look for synovitis and retraction. And for many years, we looked right past subsheath tears and didn't know what they were because they were covered by synovium, and we didn't have great lighting, and we didn't have great lenses, and didn't have great cameras. And then all of a sudden we figured out, well, if you take a little bit of that synovitis away that you're looking at, you'll see the cleft right there underneath the ECU tendon sheath on the dorsal rim. And the hook test also, you can stick the hook underneath the TFCC and raise it up so you know you have some sort of detachment on the ulnar side. For me, the arthroscopic repair confirms the diagnosis, localizes the tear, lets me get the tear debrided of all the synovitis that's really part of the inhibition of healing. You can prepare the bed and scarify it a little bit. You stabilize the tear by various techniques, and then you turn it over to your hand therapist for great post-operative care. And I usually immobilize them for about 4 to 6 weeks, depending on the size of the tear. For me, open versus arthroscopic, it's not hard. You'll find your groove as far as what you feel is a triumph of technology over reason with some arthroscopic repairs. For me, instability, I like it one time, and I use anchors and a big drill hole, and I use the 3-limb repair to pull the TFCC and the volar and dorsal rims back to the end of the ulna at the fovea, not at the styloid. And then The other peripheral tears are really done well by the scope. And these central tears, I just show them for completeness. So, excuse me a minute. Get away from this video. So the repair zone is really the rim, and the debris zone is that central portion. So here's that India ink just showing you the vascularized zone, and these are the ones that repair and do pretty well. And you can have them all the way out to the edge of the styloid, but they may include tears with fractures. Here's India ink injection just showing the great vascularity of the rim and the avascularity of the second. I use the Whipple technique that goes back to 97. You can use a lot of different methods, but the TUI needle or the meniscal repair techniques are quite good, quite reliable. Single knot techniques, cannulated needles and snares, all have been described. You got to find one and master it and feel good about it, and just get that cleft closed and get it stabilized back to the floor of the ECU. Ulnar repairs, they're peripheral and stable. You really just have to re-anchor the edge of the TFCC back to the ECU, debride it, and do your outside in portals, 6U incision sometimes, and then insert the suture retriever, pull it back through, and pass a couple horizontal mattress or vertical mattress, depending on your pattern of your tear, and then tie them on the outside and gradually mobilize them. So 1C, the least common. So reparable TFCC tears, I think for arthroscopic, for me, are the associated lesions. For open repairs, it's instability and where the TFCC is just cleaved off the two limbs of the wrist. Here is the end of the ulna, and you can do it through a drill hole up through the fovea, or you can do it with a suture anchor. I personally like suture anchors better than drill holes. And then a lot of times the end of the ulna just is bare, and you really have to put the TFCC, which is that dorsal or the distal structure, back down to the end of the ulna. And here you're looking at the triquetrum with the disc, and then the end of the ulna there. Bare ulnar head, foveal base, periphery of the TFCC. And then grab a hold of it and get it back down to bone. And here's a drill hole that you're putting your sutures in. Like I said, I use a third one, a PDS suture, to go through the limb of the TFCC. And here she is, college volleyball player, number of months later. Ulnar impaction, just basically an unloading operation by shortening. And then outcomes, there's been a lot of papers on a lot of different outcomes. I think the size of this presentation night, you could talk all night about different outcomes of either foveal tears, peripheral tears, palmar split tears, central tears. There's just a lot to go through. And that piece of real estate has a number of different pieces of pathology. So when you talk about outcomes, I think you need to be more specific about the pathology. So I'll stop there and be happy to answer questions. And I'm going to hand it over to Jessica Fischer. No relation. She's too good looking to be mine, but Jessica's been one of our hand therapists here for just a few years, but she's proved her dynamic, and she stepped up to the plate and volunteered to do this, and I'm really proud to have her on tonight. Thanks a lot.
You're muted. There we go.
Thank you, Dr. Fischer. Hi, I'm Jessica Fischer, and I'm an OT and certified hand therapist working at the Indiana Hand to Shoulder Center, and I'm presenting on the post-operative care of TFCC repairs. The specific protocol following a TFCC repair is determined by the structures being repaired and the stability of the joint, but today I'll be reviewing just a general protocol. Before evaluating the patient, therapists must obtain therapy orders and the operative note to determine a plan of treatment. The initial evaluation typically occurs 10 to 14 days after surgery. At this visit, the bulky dressing and sutures are removed and a light compressive stockinette is applied. Patients generally find this light compression very comforting and will continue to use it throughout their recovery. A long arm orthosis is custom fabricated with the forearm and wrist in neutral and the elbow at 90 degrees flexion. This is shown in the first photo. Neutral positioning allows the ligaments to be taut, but the forearm position may be changed depending on the structures repaired and as directed by the surgeon. A Munster orthosis shown in the second photo is another option. This orthosis allows the patients to perform elbow motion while limiting forearm rotation. The patient wears one of these two orthoses at all times until exercises are initiated at 4 to 6 weeks. At this time, the patient is transitioned from the long arm orthosis to a wrist immobilization orthosis, worn until 12 weeks post-op, while progressively weaning to a wrist strap. Depending on the severity of the tear and the stability of the joint, short arc active range of motion exercises are begun 4 to 6 weeks after surgery. This slide illustrates the range of motion progression moving forward. Range of motion exercises are gradually introduced to identify potential sources of pain, as all exercises should be performed in a pain-free arc of motion. If pain presents, moist heat helps to improve overall flexibility while decreasing pain during exercise. Wrist active range of motion is performed with a fist to increase dynamic stability and with the forearm in neutral and rested on the table to prevent ulnar deviation. The forearm range of motion is performed with the elbow flexed during supination and elbow extended during pronation, as this allows for increased motion and reduced pain due to the increased space at the PRUJ. As you can see in the videos, patients are educated on rotation and translation of the radius over the fixed distal ulna. For pronation, the patient will place fingertips on the volar distal ulna and apply dorsal directed pressure, while the thumb or palm applies pressure to the distal radius to rotate the radius around the fixed ulna. For supination, this is done by placing the palm on the dorsal distal ulna and applying a volar force, while the fingertips apply pressure on distal radius to rotate the radius around the fixed distal ulna. At 12 weeks post-op, a strengthening regimen begins. Exercises are performed in supination to avoid axial load to the ulnar wrist. And a lace-up circumferential wrist brace is used with forearm strengthening to decrease potential pain. However, forearm strength should be discontinued if ulnar-sided pain persists, as this may be too much strain on the TFCC. Long-term, the patient needs to avoid repetitive ulnar deviation, compression, and distraction to the wrist, including chin-ups and push-ups. A wrist strap can be used for heavy labor jobs and activities that cause pain. Following the TFCC repair, it is critical to use the patient's pain as a guide, progressing only when pain allows. Performing exercises that elicit pain may cause increased inflammation or even damage the repair. Thank you.
There was a question about Galeazzi fractures and what do I do after a Galeazzi fracture? Well, I assume that the Galeazzi's been anatomically repaired. And so I think that just put him in supination is adequate. And if they're stable in supination, so I put them in supination under anesthesia, push the ulna out the palmar side of the distal radius. And if that works and it's stable, then I just splint them in supination for a month. There's an old Swedish study that was done probably in the late 1970s, early 1980s that showed that with Galeazzi fractures, supination positioning was good enough to get them to heal. For many years we did that prior to even knowing that there was a lesion called the TFCC. So I think it's still an acceptable form of treatment.
All right. Peter, I didn't see any other questions. Are there any other questions that I missed?
No, there's, let's see, there's just a couple new that just came in. Question about your thoughts, Dr. Fischer, on the tendon graft reconstruction described by Dr. Adams and Dr. Berger. I think you alluded to the fact that you don't do tendon graft reconstructions too often, but maybe your thoughts on why.
I think there's usually plenty of soft tissue there to repair, and I think that spot weld is an extremely good place to get most of your tissue back down. You don't need much, and if I do use a repair, I do the front to back through the radius, and then pull two strands, either weave it through the dorsal limb of the TFCC and the palmar limb of the TFCC, and then pull it through a drill hole in the bone rather than going around the bone. The other one I like a lot is Amit Gupta. He's online here because I just saw him say, if you excuse the ulnar stylo repair to bone becomes much easier. That's quite good. I went through an era of fixing the ulnar styloid a lot. I don't much anymore, but Amit has a brachioradialis wraparound that's kind of an extra articular stabilizing procedure. But I just don't have a lot of need for it. But when I do have a need for it, it's a great operation if you do it anatomically. And anatomically is drill hole in the fovea, drill hole through the radius and the front to back, and a good quality skinny tendon graft, because you don't need a lot.
Great, thank you. And then there's another question about if you have any technical pearls on the dorsal outside to in repair for your marginal TFCC tears, so that you can minimize ECU irritation, and just to make sure you're not grabbing the ECU and the knot not being so irritable to the patient.
Yeah, if you have, well, I've never found a way of making the knot not irritable to the patient. I do use PDS. I use a 2.0 PDS, and the knot is fairly prominent. And I just tell the patients it's going to be there for about 6 months, and it'll be a law of diminishing returns over time. I think finding that anatomy and remembering that the obliquity of that septum between 5 and 6, it is such a big, healthy piece of tissue that you can get back down to the dorsal rim of the TFCC. And you really have to cheat towards the fifth dorsal compartment. You can release the fifth dorsal compartment and see where you are and not repair it. It's almost like you can transpose the EPL and not have to worry about it. The fifth dorsal compartment, I find if you open it, you don't have much pathology from leaving it open and knowing where it is and putting your knots, kind of cheating over to the fifth side. If you get, though, the ECU and get into the sheath itself and tie the knots, you got to avoid that at all costs. But there's an obliquity to it. You're almost going underneath the ECU with your travel of your needles from outside to in.
Great, thank you. Another question was in reference to, now the question was ECU split tear, and that may be what the participant was asking, but I'm actually more curious because Dick Berger trained me. What are your thoughts on the UT split tear? And if it's something that you repair in your algorithm for ulnar side of wrist pain, which the UT split tear shouldn't cause any instability, but just curious your thoughts on that.
Yeah, to me, it's like a tennis elbow. It's a chronic kind of insufficiency of the soft tissues. It's a linear split in the direction of the fibers of the UT ligament. And I'm not sure exactly why it hurts, but it does hurt. And if you, I do it sometimes open and sometimes I do it arthroscopically. It's a rare event for me. I don't find it a lot. It may have seen me more than I see it, but nonetheless, it's always a differential for me. And I sometimes find ulnar-sided wrist pain that is associated with Guillen's canal compression, and I'll release Guillen's canal and debride that. But it's a finding both arthroscopically as well as MR, as well as physical exam, and their tenderness is just a little more distal to the fovea, to Berger's point. It's more distal and radial for me than the classic foveal tear or foveal pain.
And also maybe what the participant had originally asked was the ECU tears in the setting of let's say mild DRUJ instability, the importance of preserving the stability of the ECU within the 6 extensor compartment, and if you have to do associated debridements, tenosynovectomy for chronic ECU tenosynovitis in that situation. Any thoughts on, does your ECU management change because you want it to serve as your secondary dynamic stabilizer?
No, I still repair the. I use a Z type opening and just repair the retinaculum over the top. But I'm more inclined to make sure that the floor is attached correctly, and because for me the chronic ECU tendonitis is a subsheath tear till proven otherwise. I mean, when you talk about chronicity, and chronic and recurrent for me is usually a subsheath tear. However, there are cases of ECU debridement in and of itself, but that was more so with chronic inflammatory diseases. I just don't see as much of it anymore as a singular pathology.
Got it. And then for, a lot of the soft tissue ligamentous injuries that we treat, let's say, for example, thumb UCL injuries, we always talk about the integrity of the ligament as a decision factor on if you're going to repair or not. Do you think that there is a point where it's too far out from the injury that even if you can get the foveal attachment back to a good bone bed, that it's just too far gone, that maybe the potential for the foveal attached or foveal portion of the TFCC to repair down? Do you think there's a time that you would say, well, even if I do it well, technically it may not heal?
Well, I've repaired chronic dislocation of the distal radial ulnar joint at 6 months, and I still found plenty of tissue to repair down to the fovea, just as long as you debride it well. You have to empty out. There's always tissue that kind of contravenes into that recess that's created by the separation of the dorsal capsule away from the ulna, or the palmar capsule away from the ulna, depends on which way it went. But I think you really got to clean out that secondary crud that fills up the joint, because the body just doesn't tolerate an empty spot very well. It really likes having a filled up space, and so I think clean out that filled up space, get back to a good capsule, and then bring everything down and around. But no, I don't think there's a time frame for the intrinsic ligaments of the wrist. Yes, there's a time frame. SL, LT, those kind. But extrinsic ligaments, I think they're still pretty well that you can find them. unless it's, been out for a couple of years or something.
And I think the last question that we have so far is still in line with chronicity. Let's say you have a distal radius fracture that you've restored, reconstructed anatomically, like a Galeazzi type, which is this example. You repaired everything, you supinated them, you think they're stable, but lo and behold, 3-6 months out, they're unstable. They're anatomically reconstructed. Is there anything that you do differently in this situation to try to give stability, or still just try to reinforce robust soft tissue around the ulnar side?
Well, that would be one where I might consider, depending on the age group, depending on the demands of the patient, I might consider the brachioradial sling that Amit described. I like that operation for minor instabilities, but major instabilities, you might end up pinning them or put a X-fix on after you've grafted them. I think that's a case for maybe a graft, Peter, if it's been a long time and you had a failed primary repair. Now, if you just supinated them and it didn't heal back down, then I think you just can do a primary open repair.
Great. And then Dr. Hanel, I'm sure you can probably see, he said, wonderful session. His question was, when it works, just the hair, that being all that you're doing, giving stability to the DRUJ, why does it work sometimes and not others? Is there something that we're missing, or?
I think for me, that's a little too vague. I got to know a little bit more about the circumstances, Peter. I think you really need to analyze what you got, and and I look for secondary problems. I mean, if I've got a good repair, and I look for secondary problems like their ulnar nerve is getting compressed, or they've got a chronic pisotriquetral arthritis, or their LT ligament got pulled. Their radiolunotriquetral ligament got pulled off the dorsal side of their triquetrum, and it's not completely healed back down. I mean, there's lots of other small pieces of pathology, ulnar styloid non-unions that don't look so bad, but they can be painful. You got to look for all these secondary things. Like I said, one time I counted them all up. I could count 24 different pathologies on the ulnar side of the wrist that have been described. I made believe in about 20 of them. I don't know, but that I think you really got to start looking for other things, because you got to trust your operation, unless you really kind of screwed up the post-op rehabbing, which is so important. And I think stiff, painful DRUJs sometimes are just painful because they're stiff. And I think that little running loop of video that Jessica showed really is one of my favorite exercises for the patients to learn, where they take the heel of their hand, take their fingertips, pull up on the ulna, and translate the radius palmarly with the heel of their hand. It's a very nice maneuver because it is a slide and glide joint. You got to get that joint mobilization, that translation going.
I was just thinking how many of the 148 participants was doing that at the same time you were illustrating that. I think probably the biggest take-home point that I have from this talk thus far is what you just mentioned here, is that there's so many factors that go into the perception or true instability on the ulnar side. So thank you for reiterating that. Let's see, Jay, do we have time for one last question here?
Sure.
Okay. And you touched on this, Dr. Fischer, but I think just to be clear, what your indications are for the open foveal repair. It sounds like you prefer the open repair because in your hands, you can do that really, really well, but do all require open repair? Are there any that you would just treat arthroscopically for a foveal repair?
Not for a full-fledged instability. There's some minor ones that I just put a push lock in or something that you can do arthroscopically. There's some great described arthroscopic techniques. The biggest problem I have is getting the trajectory and getting the anchor right down in the fovea and making sure my trajectory is good and that it's in the right spot on the end of the ulna.
Great.
think that's critical. Having it off-axis repair is just not conducive to good healing.
I think that's
Thank
a
you very much.
Pete, can I ask a question? Hey, Tom.
Chuck, you're scaring me with that picture there. Just keep your head.
It's an homage to you because I've learned so much about the TFC from you. I just want to know why you settled on an anchor, because you're a smart guy. And so you have to push the TFC down as you tie it, as opposed to pulling it down if you have a bone tunnel. And the suture, at least one of those three sutures, is going to be in the joint the way you describe it. So
Yeah.
how did you decide ultimately to use an anchor rather than bone tunnel?
Well, I think bone tunnels are a fiddle for me. I personally like anchors. I think that if you drill a big enough hole, you don't have to push it down all that much. But the first repair is that central TFCC with an OPDS that's put through the shackle, and you put your suture in, and then you pull down the other suture, and the lock suture gets pulled into the hole, and then you tie it down with a two-hand throw technique. And I think you gotta do the same for the other two. When you tie down the first suture, the other two don't slide quite as easy, but they still slide, especially if you use a coated kind of super suture that is so good these days. We've got a lot, that monofilament PDS glides very well, and you use an OPDS or a 2O or a number 2 PDS, and it pretty darn strong for tying.
Dr. Fischer, why don't we finish with two cases? We're coming up on the end of our time. Do you mind if
Let's go for it.
Cases? Okay. Let me see. Sorry, I'm just pulling those up. Sorry. Let me see here. There we go. All right, so one case that's fairly straightforward, and then another case that I thought was more difficult. This is a 31-year-old female that came to our hospital, level 1 trauma center. She had an open distal radius fracture. She's a multi-trauma patient, so multiple extremities were involved. And the distal radius, I believe, was a type 1 open, but it was washed out and fixed on call by my partner. I got called the next day, and let's just pull this up. This is kind of what they had done, open reduction internal fixation, but they had difficulty with the ulna being unstable. And so he said, I really couldn't keep it stabilized in the DRUJ. It definitely was subluxating. So I cross-pinned it, and we're, consulting you to see if you could go back at another time and do a TFCC repair. What I did was, knowing that I couldn't get her on the next day, it was going to be several days before I could get her on the schedule. I got a CT scan just to get more information. And this is kind of a representative shot that I was going to show, was that the epiphysis isn't really fully reduced. There's still translation there at the sigmoid notch. What are your thoughts about that, Dr. Fischer?
Well, I think that translation, there's a trauma paper from about 3 or 4 years ago that said that you don't need to have that translation corrected, but I really think that translation needs to be corrected, as it's just like the offset of the glenoid. You're really not going to tension the stabilizers around the shoulder unless you've got the glenoid fracture, back at the neck restored and the length away from the scapula. So that offset to me is real important to get that distal oblique ligament and your TFCC at the proper tension. So I'd take that pin out, put a radial column plate on here, leave your distal plate or your palmar plate intact, but take all the screws out and shift it over, just angulate it 2 or 3 millimeters and screw it back down, or take the whole thing off and use a longer plate if you need to. But for the most part, I use a radial column plate, screw it down and translate it. The other thing you can do is use a lamina spreader in between the radius and the ulna and just spread it side to side with a small non-clawed lamina spreader so you don't destroy the interosseous membrane there, but just distal to the IOL insertion on the ulna and spread it apart, and that usually gets my offset back.
Very good. So, I mean, I had a similar thought, was that I wanted to get the epiphysis reduced and then check the stability again. My plan was to do an open TFCC repair if it remained unstable. But what I found, these are just representative fluoro shots of the step off at the beginning. This is similar to the lamina spreader idea, but just using a reverse retractor to, instead of translating the epiphysis ulnarly, you're translating the shaft radially to get that ulnar cortex lined up. And then I didn't use a radial column plate, but I just revised the fixation to get capture and to support the fixation. And I found that it was very stable. The DRUJ was stable in all three positions. I didn't need to open up to do an open repair.
I think, Jay, that just shows how little you have to adjust that tension to make it more stable.
I'm not a big fan of cross pinning. I try to teach or discuss with my partners, like, if you cross pin something, just send it to me sooner rather than later. Like, if it's cross pin and it's 6 or 8 weeks later, as you said, if it's not completely reduced, that scar's in a bad position, or the sigmoid notch is filled with scar already, that makes it very difficult to go back and revise it later.
Yeah, and I might immobilize this in supination for a while too.
Yeah. So this is just to finish the evening, 16-year-old female. This is one of mine. She came in, she had a intra-articular distal radius fracture. This one I was concerned about just because it was comminuted and the segment, of the epiphysis was so narrow that I really felt like I needed smaller devices like fragment specific fixation to get control of the fragments for the epiphysis is so narrow. And I was fairly pleased with the result in the OR. I had a radium column plate, I had a dorsal ulnar plate, I had a volar plate supporting the volar ulnar corner. And my assessment at the time, I thought that it was very stable. I was really pleased with the DRUJ, which I tested, knowing that she had a ulnar styloid fracture. I tested that and I thought it was very stable. I thought the fluoro showed that it was very stable. But in the post-op course, I started to see this within the first 4 weeks, was that her ulna we started to see gapping at the DRUJ, which she didn't have in the OR. And with a elevated lateral, we're starting to see the ulna start to subluxate dorsally. And then this was related to her therapy as well. Like, she had a block to supination. She had pain, which, was not usual for, what we would see in the time period where she was, that we thought that her range of motion should be improving, pain should be improving. So I eventually evaluated this with the CT scan assessment of both wrists in neutral, supination, and pronation. And she was definitely dorsally subluxated much more. These are both in supination. And so you can see how much dorsal translation of the ulna related to the radius, and that she doesn't have much bony constraint. Like, her natural anatomy is almost just like a sheer, face there. So I recommended to go back and to evaluate the DRUJ, but knowing the timing was that she may be scarred in. I may not get it reduced with just a dorsal approach, that you may have to go volarly to release scar tissue on the volar side. And so my plan at the time was definitely a dorsal approach to look at the DRUJ and the TFCC. But if I couldn't reduce it, that I'd have to go through a volar approach to release the volar scar. Mark Garcia Elias talks about this as well, of releasing the scar tissue on the volar side. And that is what she needed. In fact, this is a starting fluoro here in the upper left. And then after I released the scar, I could, even with digital pressure, I could reduce the ulna back down into the DRUJ, but it wouldn't stay there. So then through the dorsal approach, what I found was the dorsal DRUJ ligaments had been avulsed off the radius. And so I removed my plates on the sides as a part of the treatment plan. And then I placed 2 acres to repair the dorsal distal radial ulnar ligaments. Do you find that you have to work on both sides of the DRUJ in chronic settings like this?
I think you have to be prepared to go dorsal and palmar. I always approach them from the sub-Q border and go palmar first.
Okay.
But put a freer up over the top and see how it is. I've already scoped the wrist usually to see what that dorsal ulnar corner and volar ulnar corner is like. That helps me to know what the stability of those two insertions are on the radius. And then this is one where, it's been out for a while. I might think about putting a 4-pin external fixator box on to hold it exactly right. And I'd probably repair that styloid too.
Okay. Those are great points. So we're going to finish tonight. Thank you, everyone, for joining us. Just as a reminder, through our sessions, the next session is November the 18th, flexor tendon repair in zone 2, which is joining us is going to be Dr. Jimbo Tang. So we're really excited about that. We hope that everyone can join us on November the 18th. And then just as a reminder that a link to the recording for tonight's session will be sent out to you 24 hours after the conclusion of this webinar for all of those who have registered. And then lastly, we've been rebroadcasting the sessions, especially session 1 was rebroadcast as a podcast. And these are online applications that you can use to access that podcast. We have that through our own website, aonorthamerica.org, on the Apple platform, Spotify, Amazon, and Google. So we're trying to increase access through different platforms. But anyways, Dr. Fischer and Jessica Fischer, thank you so much for joining us tonight. And we're really pleased that you could spend time with us. And thank you for everyone for joining us. And we're going to sign off.
Thanks, Jay. Thanks, everybody. Thanks.